Okay, I've got 3 cases lah. As Dr. Ben was saying, so I'll go straight to it. So I've got 3 cases here. So case number 1, 50-year-old lady, poorly controlled, hold on. Okay, poorly controlled diabetic, came in with a category 3. CRP on arrival was actually 2. Ferritin 163, absolute lymphocyte count 1. She was started on favipiravir because she was early in the illness. She's 50 years old on the dot, and she's got comorbidities. CRP on arrival slightly on the high side, and you can see that she already probably has some baseline ground glass on the presenting chest X-ray. Next, so she came in. So this was the next day. This is a trend of a CRP that we saw in her. So it came from 2.3, went up to 2.5, 2.9, 4.4, 6.4. So we generally only do once a day CRP. But in certain patients where we think something's going to happen or somebody deteriorates, sometimes we do tend to do twice a day CRPs, especially if the patient's still tachypnic and her SIRS, right? Her SIRS presentation is still ongoing, doesn't look like switching off. And on top of it, you can see that the ALC was still dropping. ALC went from 1 to 0.6. Subsequently, at day 6 of illness in the evening, she was actually started requiring oxygen, nasal prong 3 liters oxygen. Initially was on exertion, and subsequently on air itself, she started requiring nasal prong oxygen. So she was promptly started on DEXA. So this is actually pre-DEXA. I'll go back to this chest X-ray later. So at day 6, the highest CRP we had in her was 6.9. Absolute lymphocyte count was low. Nasal prong started requiring nasal prong. PFR is actually 2.2. She's slightly on the higher BMI side. She weighed about 80 kgs. So she was started on DEXA 6 milligram per daily. So total per day. So I tabulated in a way the dose that we prescribe and exactly how much total per milligram that she got. So per day on that 24 hours, she actually got 6 milligrams. All right. And it looked like she was responding. Right, so CRP did go down 4.1. She was less tachypnic, but the next day she started becoming more and more tachypnic, and on top of it, she desaturated a bit more. Her ferritin started going up. ALC shows no signs of recovery. Her CRP, yes, was 3.5, and then was lower than before. And this time we decided to just increase the DEXA dose. So the DEXA dose increased from sorry, hold on, I'm just going to off my phone. So the DEXA dose increased from, we decided to increase the DEXA dose because we thought 6 milligram daily tak cukup untuk her, and on top of it, she's still desaturating. So we actually gave her 6 milligrams BD. So on that total day, she actually got DEXA 6 milligrams BD. So about 12 milligrams of DEXA actually went in on day 7. But early in the morning on day 8, we found her worsened. She needed a lot more oxygen. Peak flow dropped a bit more. Yes, we were desperate when we saw the CRP went up. And this time we decided to just desperately push up the DEXA dose again. This time we pushed it up to 18 milligram, and subsequently when we saw that she was not responding at all and she still was tachypnic and required more and more oxygen, and the PFR started dropping a bit more, as you can see, CRP wasn't touched with those doses of DEXA. So it started going up to 8.8, 9.8, and of course at this point somebody had already covered for bacterial pneumonia, but the procal came back as less than 0.05. And on the day that we decided to refer to ICU, we actually gave her a total 24 milligrams. So this we decided this DEXA dose is not touching her, and we actually gave her 12 milligram BD. So actually shot in almost 24 milligram of DEXA in the span of nearly 12 hours. And this came up for her body weight of an equivalent of 1.5 milligram per kg. However, she was taken over by ICU, who just gave her metalpred 100 milligram daily, which is probably what we were giving earlier, 6 milligram BD to TDS dose. And within the afternoon, she came down to nasal prong. The response was actually really high, and in 24 hours, CRP came down to 3.9. Not only that, she only required nasal prong at 48 hours on room air, and she was promptly transferred out. Now, this is the second case, Mr. M with underlying diabetes. He's 63 years old, right? He had diabetes. He was admitted on the 21st, swabbed 2 days before, 19, CT value was about 24, came as a confirmed COVID category 2 at day 5 of illness. But by the 3rd day of admission, he started developing pneumonia, and on top of it, he already required oxygen. SpO2 dropped to about 93% and was started on nasal prong. Chest X-ray worsened, and he was started on DEXA. This was a CRP trend that led us to starting DEXA. So CRP from 2.8 baseline went up to 3.1 and 3.3 on the day that he actually worsened. ALC count was also less than 2. LDH 257. We only have 1 ferritin. Now this D-dimer came back as 43,000. We really didn't know what to do with it, but we did a CTPA which showed no evidence of PE. I think I have it later. No evidence of PE, but some ground glass changes at the basal. So this was day 5 at presentation, and this is day 8. This is the time he required oxygen. Chest X-ray doesn't show much, but the CTPA did show some basal consolidations. So he further, then the next day, he further desaturated, and the SpO2 was about 93% on nasal prong. And it worsened again. He needed more oxygen, this time 5 liters, and his ABG showed quite a significant type 1 respiratory failure. Now, the CRP trend, initially after starting DEXA 3.3, he did go down to 1.9, but subsequently the next day it ballooned up to 6.4 and subsequently went up to 9.6. This was the time where he actually required 5 liters of nasal prong, and he was very tachypneic to start off with. So during this time, 6 milligrams of DEXA for 2 days was given, and we had pushed it up to 18 milligrams when we found patient deteriorating. Despite the increased doses, he still required much and more oxygen. And the same day, he was transferred to ICU, and he was given IV methylpred 100 milligram daily the next day. And post methylpred, his response was really fast. He was able to reduce oxygen requirement to about 5 liters, and then nasal prong. Again, there was no evidence of any infection. As you can see, the ALC continued to remain low. And this was the 5 liters per minute. Methylpred, yes, granted, the X-ray doesn't really look that much. We didn't repeat another CTPA, but the earlier CTPA that was done already showed some evidence of ground glass there. So this is I'm going to finish up with this case where pushing up DEXA actually worked. So this 58-year-old man, diabetes, hypertension, presented at day 9 of illness, category 3. CRP on arrival was 4.3, ALC 0.4, NLR was 12, right? And CRP at day 10, at day 10 of illness, the CRP 2.4 went up to 4.8. Ferritin was slightly on the high side, D-dimer not that raised, started requiring oxygen. At this point, they decided to start it because the CRP was low. DEXA was not started yet, but when patients are on oxygen and still earlier on in the illness, sometimes we tend to do BD CRP, and we caught that the CRP actually went up. So almost 24 hours later, we decided to give this dose of DEXA. So we're trying this out in Sungai Buloh, where we don't really just use 6 milligram daily because we end up increasing a lot of doses. So that's why we thought we'll hit hard first. So 8 milligram stat and then 4 milligram BD. It didn't touch him. Subsequently, the CRP actually went up to 12. He was still went up to 12, but clinically, he was a happy hypoxia. He was never had any SIRS, he never had fever, it was never really that much tachypnic. And his ferritin markers, yes, they did go up, but he didn't really require any escalation in his oxygen requirement. It was just the numbers that were looking bad. So at this point, we decided to increase the dose of DEXA, 8 milligram for this is wrong. So we gave 6 milligram daily here, and then we increased it to 6 milligrams BD. All right, and then on day 3 again 6 milligram BD, and we were actually able to wean off oxygen at day 5 and tapered him off. And this guy actually never went into ICU.
Oh.
These are the cases that I have.
Good afternoon to all. I've got a couple of disclaimers to make. First of all, I think a lot of the experience here is based on conversations with Dr. Suresh, and after that, sort of changing our practice after we had first couple of mortalities. Number two, I think the good work on the ground is done by most of the specialists, which is Tan Kok Tong, Eng Kian, Shireen, and Dr. Subra. I get to present on their behalf, So yeah, I'll just sort of go through the slides. I think we know this steroid works. It probably is a class effect, and most trials had to be stopped after recovery came because of all sort of the evidence that drove the evidence for steroids for COVID-19. This is a late, and I must say before that I was quite dogmatic about steroid dosing. I insisted it should be 6 milligrams OD, and that should be the dose that we're giving patients based on recovery. And we lost a couple of patients initially, and I think I had a conversation with Suresh, and based on his experience after that, we tried to use more intensified dosing of steroids, right? A lady who came in with underlying diabetes, hypertension, came into HTW on the 19th of October. So she presented on the 17th, and initially on nasal prong. Within 24 hours, she needed high flow mask. Her RTK was 100% positive, and upon admission in HTW, she required obviously high flow mask overnight. She was already on dexamethasone 6 milligrams OD, and she next morning she desaturated further, requiring high flow nasal cannula, and that's when we decided to sort of push up the steroid dose, and she had a total of 6 doses of 6 milligrams PD. This was the initial chest X-ray when she came in, and this is a sort of blood parameters. CRP has been a very useful indicator to see that they're trending well and they are sort of improving. And so high flow mask, obviously, when she went up to high flow nasal cannula, it was pushed up, and we were able to get her back to room air fairly soon, Patient 2, 47-year-old male, no medical illnesses, but obesity. I think that's come through pretty dramatic in the sense that if you don't have comorbidities but you're obese, we see patients requiring HTW care, whose presentation was basically productive cough, shortness of breath for the week, came in tachypneic requiring high flow mask, was treated as COVID-19 while awaiting PCR. Then RTK was negative initially, was started on enfavipiravir, dexamethasone, came into HTW requiring NIV. This was the initial chest X-ray. The steroid dose was increased on the 19th. If you remember, he came into HW declaring NIV on the 18th. On the 19th, we increased it to a BD dosing, which was more in keeping of a methotrexate dose equivalent of 1 mg per kg per day. And we were able to wean off oxygenation pretty quickly. And by the 28th of October, we were able to transfer the patient out to the isolation ward. The X-ray changes perhaps a bit lagging, but I think what's more sort of impactful was the CRPs coming down quite dramatically from NIV, and obviously coming down to nasal prong on air, and also the ALCs together with the CRP count coming down. So that seemed pretty helpful when we increased these patients who came in. I mean, I suppose in a sense, who required you to do something about them, Again, a lady who had comorbidities of IHD, diabetes, had OSA, was on CPAP at home, also again had a BMI on the higher side, presented, if you look at here, presented with nearly a week of cough, fatigue, and loss of appetite. She had PCR done at 8. She was only able to come into hospital on the 14th. I think we know a lot of reasons why. Sometimes they were picked up late, initial part of it in green. So she initially required nasal prong, quickly desaturated, requiring venti mask, and correspondingly, a CRPs went up to 242, 246 as well when she required venti mask, and when she came in. And again, if you look at the trending of the CRP parameters, it came down quite quickly after the DEXA dose was increased. And she was able to be weaned off to air pretty fast after that. And just a progression of after the steroid dose was increased. Again, I think what happened then, we just increasing steroid dose based on doubling the dose from 6 milligrams to 6 milligrams BD. Then we had a thought whether it should be based on the body weight itself, and then we based it based on body weight, and it also showed the same because we had patients who were a bit more obese. When we give 6 milligrams BD, obviously it did not sort of touch them enough, and then we based their steroid dose based on their body weight. So they got equivalent dose of 1 mg per kg mitalpret by the form of DEXA. So some had 8, some had even 10 milligrams BD based on their body weight equivalent. Another example, 53-year-old male, no medical illness, again, sort of a bit in the heavier side, BMI of 31, had presented with fever and desaturated under room air, was transferred to isolation, had worsening tachypnea requiring high flow mask, was transferred to HDW, was started the appropriate medication, went in ward, and HW worsened further, type 1 respiratory failure, had persistent type 1 respiratory failure with X-ray opacities, which is worsening. We increased the dose to 6 milligrams BD for 48 hours, but the patient worsened further. We gave a stat dose of Tocilizumab then, and the patient responded sort of quite well. I suppose the question here is, instead of using Toci, if we use the higher dose of DEXA or mitalpret that patient at point, would it be any different? I think this was the initial part of things. We've since tried mitalpret for a couple of patients in HDW, and we seem to have, these are patients which we otherwise used Toci, but we tried either a high dose DEXA, which is 24 milligrams fat, which is equivalent to 2 mg per kg mitalpret, or mitalpret at 2 mg per kg. I think we had 2 or 3 patients on that, and they seem to have responded at least requiring oxygen capacity-wise, and they're able to taper off oxygen. This is the sort of, the patient went, so he was started on DEXA BD here, did not improve. We gave a stat dose of Toci on 20th, and we were able to sort of wean that patient off quite quickly, and we were able to transfer the patient to the ward initially. These are levels which were done. You expect the levels to go up after giving Tocilizumab, but this baseline level of IL-6 prior to Toci was 32. X-ray and presentation, and subsequently you could see there's obviously gradual improvement in the X-rays itself. I think this might be one of the last slides. Again, the patient with hypertension, dyslipidemia presented on the 18th. Again, BMI in the higher side, fever, cough, shortness of breath. Went to QE2 initially, tachypneic requiring high flow mask, worsening respiratory distress, intubated, went to ICU, required adrenaline in ICU. I just wanted to highlight ICU they don't usually push up the dose of steroids. They kept it on the recommended recovery dosing of 6 milligrams OD, and the patient gradually improved, and the patient was able to be extubated as well. In that course of ICU, obviously D-dimers shot up quite quickly, had a segmental branch of PE then, and was on Clexin, and this was the X-rays. And this was the progression of the patient in ICU itself, and on 6 milligrams OD, the patient improved and went to the ward itself. Just trying to highlight here, if we waited a little longer, and if we can wait for a little longer for most patients, perhaps 6 milligrams OD might be enough. But most of the time when we come to HDW, our sole aim is, well, we got 2 aims when they come to HDW. One is never let them get intubated. Number 2 is get them turned over as soon as possible because of the number of patients which are waiting for beds. So I suppose no evidence whatsoever, but the experience of increasing the DEXA dose seems to have helped get these patients out from HCW to the wards faster, which has been helpful in a way because we're able to take more patients in to HCW in the period of time which is needed. So I think from a HCW perspective, our aim was always to avoid them to get mechanical ventilated, because if they do, I think they take up HCW beds for a long time. So we're willing to try anything which sort of doesn't get them mechanically ventilated. We realized we're able to sort of turn over these patients a little faster. We think it's a class effect, obviously. I think DEXA, if you give it at the equivalent dose of metalpred 2 mg per kg or 1 mg per kg, if you give it fast enough, as in instead of giving 6 milligrams BD upfront 12 milligrams stat, well, at least the experience, perhaps it might work just as well as giving metalpred for that similar dose. We have postulated for patients who we otherwise use Tocilizumab, whether giving a metalpred equivalent of 2 mg per kg at that point would be helpful. And just a caveat, I think the majority of patients perhaps would respond to 6 milligrams OD anyway if we had enough beds, if we had enough time to keep patients in HCW for a long time. I think just the supportive care, they probably will respond to their standard dose of steroids. Just the other thing we also realized is if we taper down the steroids too fast, they probably will not. We've had patients rebound. So we've given 6 milligrams PD for about 2 days or 3 days, and then continued 6 milligrams OD. And we completed the standard 10 days. We had a couple of patients who sort of who required oxygen after that again, and we just put them back in steroids but at a lower dose, and we tapered them more gradually. And it seems to be helpful, at least thus far, from a limited 3-week experience. Who do we want to use metalpred? I think this is a sort of a paper that Dr. Patrick had shared. I think the thresholds here have been quite low, but the experience from a historical cohort, if you had a CRP which is more than 100 or ferritin which is more than 900, or a D-dimer which is elevated, but here was just oxygen saturation of tachypnea, they used metalpred. And there seemed to be a benefit in these patients when it comes to mortality and reduced use of invasive mechanical ventilation. Tocilizumab, I think it's still people. We don't have a good answer whether Toci works. I think increasingly we're trying to sort of fit in where they fit into the whole scheme of things. Just a couple of slides on whether cytokine storm is even the appropriate term for most patients. I think there's another paper that probably was shared by Suresh as well. If you compared it to patients with sepsis, patients with cut-induced proper CRS and ARDS, whether it's the hypo or hyperinflammatory phenotype, the interleukin-6 levels, the CRP levels are not dramatically as high as even compared to cut-induced CRS or ARDS, or even sepsis for that matter. And people are beginning to think that perhaps the cytokine storm does not describe the whole organ dysfunction related to COVID-19. Probably it's less, probably even it's an inappropriate response to the level of inflammation which is happening to this patient. And the paradigm of thinking is perhaps it's more of a violin-induced injury to most of the organs, because as you know, in post-mortem examinations, you could find vial samples in sort of most parts of the body itself. And the thinking is perhaps the steroids here works by reducing late onset fibrosis that reduces irreversible ARDS. I think that there are more questions than answers. I think the trials have said steroid work, but I think there's a lot more questions on the optimal dosing of steroids. Whether it should be individualized based on CRPs. I think we have seen inflammation rebound when we stop steroids in our patients, definitely, and how we sort of manage that. I think there are a lot of adverse effects. I mean, we were struggling with a lot of patients who had very bad hypoglycemia, where a patient went to DKA giving such high doses of steroids. I think that's not been sort of well publicized in most of these steroid trials. whether patients who are not ill and non-hospitalized should be treated steroids. I know the recovery said if you don't require oxygen, you don't get steroids, but perhaps there's a question, there's a role whether there's steroids earlier would be helpful. And the severity of steroids when it's indicated, and whether antivirals is actually needed when you're giving steroids. I know the NIH have recommended that, but I think that's still open to question. What we have done, we sort of tried to rationalize it, again, based on no evidence whatsoever. So if you're less than 75, you give 6 milligrams BD. If you have a sort of inflammatory response which suggests you're not doing well based on oxygenation and also CRBs. If you're more than 100 kilos, you get 10 milligrams. And the duration is usually 3 days to see whether it works. And we try to taper it now more gradually, perhaps over 14 days. But certain patients obviously need it over 21 days. Yeah, with that, I'll thank you.
Okay, this is a 79-year-old Malay gentleman. It's actually a prisoner from the camp Tahanan Taiping. He had multiple comorbid diabetic hypertension and chronic kidney disease. He presented actually with a very short duration of illness, fever, cough, running nose, for 1 day before the admissions to the Taiping hospital. So when he went to the Taiping hospital, patient already on Nasoprom oxygen, and he had a COVID tested positive and the CT value was 20 that times. So he couldn't maintain saturation on Nasoprom oxygen. Subsequently, this patient was intubated on the same day. So patient went to Taiping hospital. So we took over these patients from Taiping on the next day, which is on the day 3 of illness. He was actually on the SIMV 0.5 and he had a type 2 respiratory failure. BP still stable that time. So because this patient actually had an underlying CKD whereby the creatinine clearance less than 30, so we didn't give a patient Favi. Instead, we giving him Calitra together with interferon and dexamethasone. So Tamiflu also started. He had an influenza B co-infection as well. Started broad spectrum antibiotic and furosemide him because we think clinically he looks overloaded, and that was proven with a bedside scan as well. So we had done an echo in the ICU setting itself. This patient was already transferred to our ICU settings since arrival on the 13th October until today. But unfortunately, this patient actually passed away after a month stay in our hospital today. So he had an echo done which revealed the good ejection systolic functions, and our IVC was dilated. So for that, we try to offload these patients at the same time. And the X-ray already show, and the lung scan already reviewed that there is a ARDS changes. So this initial X-ray we have for this patient on arrival. So this is a chronological flow of these patients. We came in on the day 3 to hospital Taiping, day 4 to our hospital, and he had this one. His hemodynamics is actually throughout stable since admission, and BP and it was air rebound, and his parameters wise, ALC always at the low side, which is less than 1 since he came into our site, and the CRP range is 50 to 100. PF ratio actually was very bad. He had a severe moderate this one ARDS, and on arrival subsequently is become better from 160 to 300 over the next few days after we started this our standard treatment with dexamethasone. So he actually undergone few sessions of the SLAT and also CVH in our ICU. So subsequently, after a week of the stay in the ICU, this patient actually was transferred to our general medical ward because we able to wean off, extubated these patients on the day 6 of on the arrival, and then put on the high flow nasal cannula and then change to nasoprom oxygen for 24 hours in the ICU before transfer to Gen Med. But however, on the day 11 illness, which is day 7 of the stay in our hospital, patient desaturated in our general medical ward. And actually at that particular point, we have completed a week of dexamethasone, and we have finished off 1 week of Calitra interferons. Actually, interferons is given for 2 doses. only lah. And actually, we didn't taper this patient dexamethasone that time because having looking into, he had a very good CRP and the PF ratio actually was quite acceptable before we transfer out these patients. So I think that probably actually had contributed to the rebound where we have after 24 hours when we off the dexamethasone. So this is the PF ratio of the patient for the first 2 weeks when the patient came to our hospital. Initially, he had a PF ratio of 160. Then subsequently, he was transferred out from the ICU since on the 20th of October. So there was a day when we off the dexamethasone, we completed his antiviral treatment as well. So on the 20th itself, after transfer of the ICU, patient desaturated, and we off the dexa actually on the 19th. If you look at the trends of the ALC, actually is keeping at the low sides. There's also contribute to the severe warning sign he had. So these are actually changes every alternate days we had. It sort of improved before we transfer this patient out. And this X-rays on the 20th, we can see that actually there's a new the ground glass opacity actually more prominent as compared to on the 18th of October. So I just skip this, and there's an event. There's a chart that actually I want to show. Okay, so the patient actually came in on the blue line is actually reflecting on the PF ratio, and the black lines actually is a CRP level, and the orange colors bars is a ferritin level. We didn't monitor this patient ferritins daily, but we actually monitor his CRP, and also I plotted out the PF ratio. So you can see that actually at initially when we started, when we admitted this patient, we given Dexa 6 mg OD right from the beginnings when we on the day ones. So subsequently, after a week of Dexa, we actually off it 6 mg OD, and then the next days when the patients are transferred to a general ward, then we noted actually the PF ratio dropped drastically, and the CRP also upgoing trends. So after that, patient transferred back to ICU and re-intubated. 2 days later, we started this patient on the IV Tocilizumab and 1 dose. And then you can see the black color lines actually the CRP downgoing trend after we started Toci, and the PF ratio also improved. So Dexa was off after we started on Toci for these patients. But unfortunately, this patient subsequently passed away after staying a month in the ICU. We have difficulty ventilating this patient because of ARDS. He had type 2 respiratory failure, and he has also had some nosocomial sepsis, whereby the tracheal aspirate actually grows sternotrophomonas maltophilia with antibiotics and also CVH dose and dexamethasone, but couldn't revive these patients. So he passed away today, and the cause of that is actually COVID stage 5 with multi-organ failure. This is the latest X-ray we have 2 days back. Thanks.